Hello and good evening, everyone. Welcome to the Cottage Heart and Vascular Center Meet the Doctor virtual event. I'm Christina Cortez, Public Relations Manager for Cottage Health. Hola y bienvenidos a la consulta virtual con la doctora de Cottage Heart and Vascular Center. Soy Cristina Cortez, Gerente de Relaciones Públicas de Cottage Health. Before we begin, I want to mention that we are using an interpreter feature. I ask that everyone please take a moment right now to choose your preferred language. Click on the globe icon on the bottom right of the Zoom screen to select your language of choice. This will ensure that the language you hear will always be in your preferred language throughout the presentation. Antes de comenzar, me gustaría mencionar que estamos utilizando una función para la interpretación, así que tómese un momento para elegir su idioma. Haga clic en el icono del planeta ubicado en la parte inferior derecha en la pantalla de Zoom para seleccionar el idioma que prefiera. Así, el idioma que escoja será el que escuchará durante toda la presentación. Please also ensure that you are connected to your computer audio rather than calling in via telephone so that the interpreter feature will work on your Zoom. Verifique también que esté conectado el audio de su computadora en lugar de llamar a través del teléfono para que la interpretación funcione en su Zoom. If you're joining from a mobile device or iPad, please click the three dots on the bottom right of your screen. Select Language Interpretation to select your preferred language, then select Mute Original Audio and click Done to return to this screen. Regardless, if you're a native speaker, you must select a language. Si se conecta desde un dispositivo móvil o iPad, haga clic en los tres puntos de la parte inferior derecha de la pantalla y seleccionen Interpretación para elegir su idioma. Luego, haga clic en silenciar el audio original y por último, seleccione Finalizado para regresar a esta pantalla. Sin importar su idioma materno, debe seleccionar un idioma. Las diapositivas de la presentación del día de hoy estarán en inglés. Para ver una versión en español, haga clic en el enlace que verá en el chat. At the conclusion of this webinar, we will host a brief question and answer session. So please use the Q&A button to ask Dr. Ahmed a question. This webinar is also being recorded and will be emailed to you to view again. The slides we will be displaying today will be in English, so to view the Spanish slides, visit cottagehealth.org/Spanish MTD in a new window. This has also been posted in the chat box. It is now my pleasure to introduce Dr. Bina Ahmed. Dr. Ahmed is an interventional cardiologist and structural heart disease specialist with a strong interest in advancing women's heart health. Her career path has included specialized training focusing on better understanding sex-based differences in cardiovascular diseases. She works to use her interest and expertise to enhance all aspects of cardiovascular care in women, from prevention to intervention. So now, without further ado, please join me in welcoming Dr. Ahmed.
Thank you, everyone, for being here today virtually with me. Thank you for taking the time to tune in. I am absolutely delighted that I get to share some of my thoughts on a topic that I still think is very pertinent and important. But before I begin, I want to take a second and thank my Cottage team for facilitating this event. It sounds like we have set some records, and it really is a testament to their good work and their hard work. So thank you, guys. I'm also delighted that this is available for our Spanish-speaking listeners. That's a first for me and much needed. So kudos to the Cottage team. I gave a talk on women and cardiovascular diseases when I first arrived in Santa Barbara about 4 years ago. And today I thought I'd give you somewhat of an update on the progress we have made, a few lessons we've learned along the way, and also take a look at where we might be headed. I also have some very, very exciting news to share with you all, and we'll get to that towards the end of the talk. but I hope to speak for about 30 minutes and do want to leave enough time for questions. So please submit any questions that come up as we go, and we will get started. I used to show this slide for the simple purpose of highlighting that in many ways, including cardiovascular disease, men and women are simply not the same. But perhaps this unfairly simplifies men and overcomplicates what it is to be a woman. And so instead, I thought today I would use a different analogy for this talk. I am a cloud lover, and so I thought I'd try a cloud-based analogy to drive the message home. So maybe when we think of men with CVD, we think of them as being equivalent to a beautiful, plain, sort of banal blue sky. There's not much to this picture, but it's still easy to appreciate. But when we think about women with CVD, on the other hand, they tend to be represented better by a landscape that tells a more complex and dynamic story. I do think both landscapes are worthy of our interest and attention, but perhaps the latter, requires us to look a bit closer. So let's take a closer look, first at where we started and then at how far we have come. I was able to find this figure, which was published in 1997. This shows cardiovascular disease-related mortality among both men and women dating up to 1993. And we all can appreciate the diverging lines in men and women. Starting in about the mid-80s, we noticed that men had significant improvement in cardiovascular death rates, most likely secondary to advances in medical therapy. Statins were starting to show promise. We also were seeing benefits of aspirin for primary and secondary prevention, and bypass surgery really was starting to get safer and come with clinical improvement in patients with coronary artery disease. But the story was a lot different among our female patients. Dr. Lori Mosca, who authored this paper, first sounded the alarm on what was happening among women. She urged that we better assess the impact of CVD in women, that it be a public health priority, that we increase awareness among patients and providers. We enroll women in cardiovascular trials because that really wasn't a thing at that time, and really think about using a multifaceted approach to lessen the impact of CVD among women. Well, let's fast forward a few decades, and how did we do? And these are the most recent statistics from the AHA, taking us up to 2020. And I think there's some really good news here. Around the year 2000, you can appreciate what was happening to mortality rates among women. Scientific communities like the AHA, the ACC in the United States, and others globally put forth a mandate to really try and better understand what was driving these unfavorable trends in women and how to sort of narrow the gap between the two. And thanks to a colossal effort, I think we've seen what good science, advocacy, and commitment can do. In a mere decade, from 2000 to 2010, we not only halted the progression of CVD among women and its adverse effects, but saw a near 20% decline in mortality among women. And I think that's pretty incredible. At first, I was going to leave what's happened between 2010 and 2020 alone, but I do think it's worth mentioning the not so favorable trajectory that we are noticing in both men and women over the last decade. There's a fair amount of conjecture and worry about what might be driving some of these trends. Maybe atherosclerosis is modifying its expression. Maybe as a race, we're less healthy, more obese, more diabetes. And so this is definitely something to keep an eye on. But in general, what we can see is that all the attention and focus on CVD in women had quite a profound positive impact. I did want to share with you some of the specific movements that I think have helped promote this positive effect. There have been many professional and patient-based advances and advocacy campaigns that have had quite a profound impact. All this work has come together to really create the swell that we needed to flesh out sort of the stagnant approach on women and CVD. Some notables on the patient side, include the creation of support campaigns like the well-known AHA, NHLBI, Go Red for Women, and the Heart Truth campaigns. In addition, Women Heart, which is a national coalition that has done a lot of great work for the cause. And we actually have a chapter here in Santa Barbara that's led by amazing volunteer champions, has done some incredible work to provide support to our patients with CVD. There also has been a tremendous amount of work done on the professional side. We had the first ever publication of sex-specific guidelines on prevention of CVD in women in 2004. Several updates have followed since then. And so this is sort of a broad stroke summary and just some of the highlights. But there's been so much more work that has been accomplished that has really led to us coming together and talking about this topic today. Next, I want to spend a few minutes and talk about a couple of specific diagnoses and really highlight how I think clinical research has changed our understanding and brought to light some sex-specific differences. I chose two diagnoses to discuss that I think are most relevant. Both of them have to do with coronary artery disease. First is one that continues really to confound us in practice even today, and really speaks to the differences in mechanisms of atherosclerosis, and that's plaque buildup within the arteries. There's some key differences between men and women. A quick anatomy lesson. This is one of my favorite pictures of the circulation of the heart. You see three major arteries, which are known as the epicardial coronary arteries. They essentially sit on top of the heart muscle and act as conduits through which blood flows to maintain heart muscle function. These are also the ones we are studying when we do a coronary angiogram to look for plaque buildup in one or more of the arteries. The surrounding arteries that you see in this picture are the coronary microvessels. These vessels are so small that we cannot visualize them. There are tens of thousands of them that are embedded within the heart muscle. And what we are learning is that these microvessels play a much more important role among women with coronary artery disease. Coronary microvascular dysfunction is a clinical entity that involves alterations in the function of these dynamic and complex small blood vessels. Either these arteries are unable to relax or they constrict or narrow inappropriately. Both of these can sort of lead to impairment of blood flow to the heart muscle and symptoms consistent with chest pain or pressure, or even sometimes presentations with heart attacks. Now, up to, I would say, a decade ago, testing for coronary microvascular dysfunction was very challenging. Oftentimes, this was a diagnosis of exclusion. We couldn't prove that it was happening. It may have been possible that it's happening. But I would say in the last 10 years or so, we have defined ways that we can make this diagnosis reliably, both using catheters and wires and also using CAT scans and MRIs. And so once we make the diagnosis, we also know that we want to treat these patients with microvascular dysfunction. Two aims of treatment include treating symptoms, because oftentimes the angina and the chest pain can be very disabling. And then also, we know that having this in our younger years often does portend a poor prognosis down the road. And so risk factor modification should be of utmost importance in these patients as we continue to follow them. Another finding, which I think speaks to how coronary artery disease differs based in sex, is the finding that women tend to have more diffuse and less obstructive disease within the blood vessels that feed the heart muscle. These are the big arteries that I was talking about earlier. In general, when men present with their heart attacks, like the two we had this morning, they really truly have sort of the classic Hollywood heart attack. The symptoms are classic, our findings are classic. And when we go to look at their arteries, we find a narrowing or a focal area within the blood vessel that explains why they came to the hospital. Women, on the other hand, will oftentimes present with classic symptoms. Will do blood tests that suggest they're in the throes of a heart attack, but women actually are 2 times more likely not to have any focal areas of narrowing within the blood vessel to explain their presentation. It's an entity called heart attacks with open arteries. Role of stress, flow dynamics, hormones, as I was discussing, the microcirculation, all are thought to play a role. But we still really don't fully understand why this key difference exists in how atherosclerosis and coronary artery disease expresses itself in men and in women. Next, I'd like to discuss another diagnosis exclusively seen in women. It is called SCAD, or spontaneous coronary artery dissection. I can vouch for how much our understanding about SCAD has changed just in the last 10 to 15 years. I'm 100% certain that when I was in cardiology training, we saw many women coming in with SCAD, but almost none were correctly diagnosed. There's been a massive campaign to better understand and spread the word about SCAD. It tends to be more prevalent among women in their 60s, but oftentimes is responsible for heart attacks in younger women. And what this is a spontaneous tear in one of the major heart arteries. And I think the reason it's so important to know and to be looking for SCAD in the right patient is that the recommended management really can be different. Oftentimes, trying to relieve the blockage with stents in this situation is not necessary, and sometimes can worsen the presentation. Just by trying to put a wire and stent down these blood vessels, we can propagate the tear further. And so we do have to be thoughtful when evaluating patients that are presenting with SCAD. We know that high blood pressure and probably some undefined and yet incompletely understood genetic risk can predispose women to SCAD. Interestingly, this is the most common cause for a heart attack in pregnant women, and there does appear to be a role of sex hormones in driving that risk. So I think this still gets missed. However, it's much less likely to get missed or misdiagnosed than it was even 10 years ago. And this really is a testament to some amazing female clinical interventional cardiologists and researchers who have committed to a better understanding and defining SCAD. Now, let's shift our focus to prevention. And here we have really seen a major shift in our understanding of cardiovascular risk, especially in younger women. Young women are a group that is of particular concern because we are seeing consistent data showing an increase in cardiovascular disease mortality among our younger women. This is a figure from the Lancet Women and Cardiovascular Disease Commission publication. I think this was published maybe 2 years ago. And this is an initiative that is focusing on reducing the global burden of cardiovascular disease among women by year 2030. We know that there are well-established risk factors that put both men and women at increased risk of cardiovascular events. These are things that we're aware of: high blood pressure, high cholesterol, diabetes, being sedentary, smoking, etc. But what is being missed really is the link between certain sex-specific risk factors and cardiovascular disease down the road, a decade or two after. We now know that premature loss of estrogen is associated with increased cardiac events. We know that conditions of pregnancy, such as diabetes, having elevated blood pressure, preterm delivery, all can increase risk of cardiac events 10, 20 years down the road. Polycystic ovary syndrome comes with a twofold increase in cardiac events. And then specific systemic and autoimmune inflammatory disorders such as rheumatoid arthritis and SLE, they are way more common in women, do put them at risk for increased cardiac events, again, a decade or two down the road. And so, if we're not evaluating our younger patients for these sex-specific risk factors, we potentially are missing an opportunity for risk optimization and leaving these patients at risk. There are also some under-recognized risk factors that are more related to gender roles of women in society. And these include psychosocial risk factors, abuse and intimate partner violence and its effects, poor health literacy, and really other social determinants of health. And so a part of the call to action has been to ensure that when young women are evaluated by their, say, OBGYNs or their primary care providers, we avail the opportunity to provide appropriate risk assessment based in sex, and then follow it up with counseling and treatment if needed. Next, we have to talk about HRT. Each time I give this talk, I hope that the tide will turn on our approach to HRT, both from the patient perspective and the provider perspective. This is a very brief look at how we got to our current relationship with HRT. In the 1980s, there was an observational study that came from a study of nurses that suggested that women taking HRT were at a lower risk of cardiac events like heart attacks and strokes. And based on this finding, the NIH funded the Women's Health Initiative, which was a much larger study looking to evaluate many different things. But one of them included performing a randomized clinical trial, sort of our gold standard of testing any hypothesis, that specifically looked at the effect of HRT in postmenopausal women. Their primary aim was to assess cardiovascular benefits, but they were also looking at benefits such as preventing bone loss and assessing cancer risk in relationship to HRT. There were two arms to the study. One included estrogen plus progesterone. This was in women who had a uterus, and among women who had had a hysterectomy or removal of the uterus, they were only given estrogen without the progesterone. Of note, only oral estrogens were used for this particular study. About 10 years after the initiation, in 2002, the trial was abruptly halted because initial data was showing higher rates of heart attacks among women who were receiving HRT, namely estrogen and progesterone. The estrogen-only arm of the study was allowed to continue and eventually showed no signal for cardiovascular harm. What this did was essentially took tens of thousands of women who were taking HRT, and they abruptly discontinued their treatment. I'm sure all of us remember the headlines. This was a very big deal. But a year after the publication, the authors did more of a deep dive and a detailed analysis of the findings, and essentially noted that if HRT was started within 10 years of menopause, there actually was no signal of harm and even possible benefit from the cardiac standpoint. And now we have a ton of randomized clinical data that sort of supports this notion of the hormone therapy timing hypothesis. We know that in younger women without established cardiovascular disease, HRT actually is beneficial, or hormone replacement is beneficial. It can help cause relaxation of the blood vessels, lower the inflammatory potential within the blood vessel, and also stabilize whatever plaque that might be built up within the blood vessels. But If HRT is started in someone who already has established atherosclerosis, somebody who's older, has had a heart attack or stroke in the past, then we also know that HRT can have detrimental effects. It can do the opposite of what it was doing in terms of benefit. It can promote inflammation, promote narrowing of the artery, and increase risk of cardiac and vascular events. And so for women who are younger, perimenopausal women in their 40s and 50s entering menopause, the data tells us that HRT, when used to treat menopausal symptoms, comes with the benefit of lower mortality, less incidence of diabetes, improved cognition, less bone loss, and less cardiovascular events. Now, I will say that from the WHI, we saw a signal for mild increased risk of stroke in younger women and also of all cancers. And we don't have quite an explanation for why this may occur, but these were the findings. In older women, say women older than 60, we do see benefits of HRT, obviously treating menopausal symptoms, less bone loss, less diabetes, but this is offset by sort of signals of harm, so higher rates of cardiovascular events and also cancer risk. And so as it stands now, I do think that when we assess patients for HRT, you have to assess their cardiovascular risk. For patients who are at low risk for cardiovascular events, their 10-year risk is less than 5%, they're having menopausal symptoms, I think it's reasonable to consider lowest dose of HRT, the safest preparation, perhaps transdermal, for the shortest duration. On the other hand, if you have a woman who is high risk for cardiovascular diagnoses, they've had a heart attack or stroke or have high cholesterol, multiple risk factors, those women may not benefit from HRT, or the balance may be more neutral. So in those patients, unless the symptoms are disabling, I would advise against using HRT. And then there are women in between that I think deserve at least an individualized assessment. And so in summary, as far as HRT is concerned, I definitely think there needs to be a resurrection as far as us talking about it. At least we know that it no longer should be used for reducing cardiovascular risk, but when started in the perimenopause to treat sometimes what can be disabling symptoms of estrogen loss, there should at least be a discussion about its merits, its benefits, and its risks. All right, so let's look ahead. And despite all the good work and what I have shown you as progress, there's still many parameters that continue to show us that CVD in women remains understudied, underrecognized, underdiagnosed, undertreated, and that women are and continue to be underrepresented in clinical trials. This is a global problem, and like I said, though we have taken some important steps in the right direction, much more work is ahead of us. As it stands now, 1 in 3 women globally will die of CVD. And again, I mentioned the Lancet Women and CVD Commission report. This is really a call to action to define ways that we can reduce the global burden of CVD in women by the year 2030. Now, I think some of this will have to center around continuing to raise awareness among women and their clinical providers to not only think about optimizing traditional risk factors, but also thinking about some of the sex-specific risk factors that I discussed here today. I also want to remind you, and nobody believes me when I say this, but 90%, that's 90% of CVD risk is preventable. And it really is a matter of women knowing their risk, taking steps towards improving their risk, and actually lowering their risk, and providers paying attention to how risk differs in women. One specific way that we can facilitate this is at a women's heart center. These have developed in response to the need for improving outcomes in women with cardiovascular diseases. The mission really is to offer accessible and expert care to all women from all backgrounds. They allow us to apply best practices and guidelines. They represent an opportunity for us to address the specific needs of women throughout their life. And as I'd mentioned, the sort of risks and the face of CVD really does change as we progress through different stages in life. These centers also represent a way for us to provide education to patients and providers, offer multidisciplinary and medical team approaches when necessary to treat our more complex patients. And a lot of the research that I presented to you today has really come from heart centers for women over the last 3 decades and have really changed our understanding of CVD in women. And so they serve a very, very important purpose. And so to that end, I am so very excited to announce that we will embark on our own women's heart program and clinic here at Cottage Hospital. This has been several months in the making, almost a career in the making for me. But we expect to launch our clinic in February of 2024 at the start of Heart Month. Our mission and expectation is to focus on 3 things. 1 is clinical care, 2 is education, and 3 is research. Our clinic will offer expert consultation to women for management of various cardiovascular diagnoses, from the simple to the obscure, focusing on primary prevention, sex-specific risk optimization, and secondary prevention among women who have established CVD. In addition, I want to take advantage of all the great talent we have available in terms of providers and other specialties here in Santa Barbara, and be able to provide multidisciplinary care, to patients who are more complex. And when this is needed, it really does help improve outcomes for patients who need it the most. In addition, we want to educate our patients about their specific understanding of CVD, of female-specific risk factors, and ways that they can optimize their personal risk. We hope to continue to empower patients with knowledge through, obviously, consultation, educational conferences like today, newsletters and publications. And I think sometimes as providers, we get too busy and forget to arm our patients with perhaps one of the more powerful tools, which is education about their risks, about their treatments and/or disease. And lastly, I do think that contribution and collaboration to improve cardiovascular outcomes through research and science is essential. And this is really the only way we can increase representation of women in clinical trials, so that we can continue to garner and learn about very important differences in disease pathology and management and different treatment options. And so my hope really is that we offer and allow women to have access to thoughtful and focused cardiovascular care, from prevention to intervention. And I really am excited and delighted that we can make that happen for our patients in Santa Barbara. So thanks again for being here today. I hope you leave knowing that women are not small men, and that CVD and its management and treatment really should be sex specific. We have a global call to action to mitigate the impact of CVD in women. And though the work in progress has been significant, there is much more to be done. And so I hope to continue that work here in Santa Barbara through our Women's Heart Program. Please stay tuned, and thanks again for listening today. We can open it up to questions.
Alrighty. Thank you, Dr. Ahmed, for that wonderful presentation. So now we'll open the room for questions. So a reminder, please put your questions in the Q&A box and I'll read them off to Dr. Ahmed for response. So during your talk, we received a couple of questions. The first one is, I have been diagnosed with osteoporosis and want to start taking calcium supplements. However, I had a very high calcium score and am concerned about further calcification of my arteries. Should I be concerned?
Yeah, that's a great question. So the good news is that the exogenous calcium that you are going to take to replete some of the calcium in your bones really does not make its way into the arteries. And so there is no indication to withhold calcium supplementation for to prevent bone loss based on a calcium score.
And at what age do we start assessing cardiovascular risk, non-CHD in young women?
Yeah, another good question. So this requires, I think, you knowing some of your risk to begin with, and that may have to do with your genetics. So if there is a family history of multiple family members having heart attacks or strokes in their younger years, then you may want to start being screened in your 30s for blood pressure, cholesterol, etc. But if there's no family history in general, I think as women turn 40, that's when we start to see changes in their cholesterol and blood pressure. And obviously through changes of menopause, that becomes even more evident.
Are there any specific lifestyle changes that you recommend for women?
Yes, come see us in the office, and we'll give you more detail. No, this is so important. I think obviously being active in Santa Barbara really allows us to do that all year round. That's key. The recommendation is 30 minutes of some form of exercise that is moderate in intensity on most days of the week. That's kind of the generic recommendation. But in addition, I do think we are what we eat, and there's more and more data to show that diets are A, hard to follow, and B, the results are somewhat mixed in terms of their benefits. But a plant-based diet tends to be the one that that comes with the most consistent benefit. And I tell my patients it's very hard to be completely plant-based, but as close to plant-based as possible, or at least being mindful about getting there.
Okay. What are some cardiovascular risks or for somebody who has hyperparathyroidism? It's a mouthful. And are there cardiologists that specialize in that?
Yeah, so unlike the thyroid gland, which is close to where the parathyroid live, there's not that much interaction between a hyperparathyroid gland and cardiovascular risk, but you do have extra calcium floating around in your bloodstream, which can have effects on heart rhythm, etc. And so I don't think we have specialists that, at least cardiovascular specialists that focus in this, but endocrinologists who treat hyperparathyroidism are well versed in sort of the cardiac things to look for.
Okay, great, thank you. Can most CVD be caught early on through blood testing, or are there specific tests to get?
Mm-hmm. Right. I think I may want to mention that when we talk about CVD, and I've been using that word all throughout my talk, it really is an umbrella term for many other different things. One of them, I talked about coronary artery disease. That is a form of CVD, high blood pressure, heart failure, congenital heart disease, stroke. All of those kind of are components, different components of CVD. And so it's there is no one blood test that obviously looks for that, but things like measuring your cholesterol, measuring your blood pressure, those are surrogates for your risk of having a cardiovascular event.
Okay, Here's a good question. If a postmenopausal woman has to go off HRT due to breast cancer, what can she do to minimize the CVD risk of an estrogen depleted environment?
Mhm. Right. Right. So breast cancer in particular is essentially a contraindication to being on HRT for the most part. And so, if we're talking about optimizing cardiovascular risk, then we would concentrate on doing the usual things, the lifestyle, the blood pressure, the diabetes risk. In terms of treating menopausal symptoms, that gets tricky, but there is some data. It's not great data, but some data that shows that SSRIs, medications such as Celexa, Paxil, they're commonly used to treat depression. They do have mechanisms to help suppress some of the postmenopausal symptoms, like hot flashes, et cetera. So they can be used, and sometimes they may not completely cure you of your symptoms, but they could definitely make the symptoms better.
Okay, thank you. Is there any benefit in taking aspirin as a preventative before any heart event?
Mm-hmm. Yep, I didn't mention the aspirin story, but we have changed our approach for using aspirin for primary prevention. If you've had a heart attack or a stroke, there is absolutely an indication for aspirin. But if you have not had a heart attack or stroke and your risk is low, then the newer data tells us that there isn't clear benefit for taking a baby aspirin for primary prevention. That has changed in the last few years based on some large studies. But I don't, oftentimes I see patients in clinic who had a heart attack 2 years ago and they said, hey, I came off my aspirin because I saw the study. That study did not study those types of patients. It was only for primary prevention.
Okay, thanks for that insight. Does osteopenia put otherwise healthy, physically active women at risk for cardiovascular disease?
I don't think that has borne out a link between those two. Oftentimes, people who have osteopenia tend to be less active, and that in some ways may relate to your cardiovascular risk. But no, the two, as far as I'm aware of, do not. Osteopenia does not put you at risk for cardiac events.
Okay. And this one, we may not have the answer to, but I will throw it out there. Do you think that the return popularity of beef, especially like Wagyu beef, which is loaded with a lot of fat, may have something to do with the rise of heart disease?
Yeah, I'll add that to the list of possibilities. The one thing I didn't mention was, I think that last sort of sharp incline that we saw, or increase we saw in 2020, may be COVID related. And so it usually takes a little while for us to actually figure out what is driving those findings. And it's been 3 years now because I think that data was till 2020. But sure, we can conjecture that.
So we have another question that's really good. As a busy mom, I have good intentions of diet and exercise, but can't always follow through. If young women with predisposition were to do one thing, what would it be?
That is a very good question. I think between diet and exercise, I will say that the diet probably has the more profound impact. In younger women, I feel exercise comes with additive benefits of being outside and sort of just taking time out for yourself. But purely speaking, for cardiovascular benefits, I think if you can optimize and improve your diet, you probably will derive the most benefit. But yes, it's a challenge, and I think that's why younger women, especially as they're having babies older, are kind of ignoring some of their risks and the care that they need.
I guess this is a good transition to the next question. At what age should somebody start seeing a cardiologist, especially if they have family history?
Yeah, and that depends, I think, on your primary care provider. If you have a very good primary care provider who is doing the basic things like checking blood pressure, making sure cholesterol's good, running some of the screening tests, I think oftentimes that's appropriate. Now, obviously, if there's multiple risk factors that are not controlled or poorly controlled, then there is benefit to counseling and coming in and seeing one of us. But it's tricky. We do see a lot of patients for consultation for a family history, and it turns out it's not even a real family history. And so it really just does depend on sort of your relationship with your primary care provider.
And are there any other nutrients or supplements other than HRT that may benefit women in their 6th or 7th decade?
That one is tough for me. I'm not an expert in in nutrients, but part of sort of the reason for having a women's heart program is really to open ourselves to not just Western medicine, but a more holistic approach. And I would love to partner with somebody out there who does have an interest and expertise in sort of nutritional supplementation and heart health.
For a young woman in her 30s with PCOS and sedentary job, would exercise be the best option to lower CVD risk?
Yeah, in combination with making sure blood pressure is good, cholesterol's where it should be, and also sort of consistent follow-up with a provider. Oftentimes these women just get lost to follow-up for 10 years and come in, either with progression of heart disease or kidney disease, et cetera. So I think it should flag you as somebody who is at a higher risk and should be in touch with the medical system and get risk assessed on a regular basis.
Mm-hmm. We received another question about beef, so we'll follow up our.
Say no to the beef.
What about the quality of beef, such as 100% grass-fed, which is high in CLA and omega-3? What do you have to say about that?
Well, the last time I had beef, I think I was 19 years old. So I don't know. Is it better that it's cleaner? I bet that is true. It doesn't sort of change. Kind of the detrimental effects that it comes with. And obviously I'm not asking anyone to give up beef permanently or red meat. You just sort of have to be mindful and what percentage of your diet does that represent. And so yeah, I bet it is better that it's organic, grass-fed, and the cows get massages, etc. So
if you don't have any menopause systems, but obviously your estrogen is low, should estrogen be taken?
Right. So very important question. The way HRT is approved, really the first question is, are you having symptoms of menopause or estrogen withdrawal? And those are well defined. In the absence of that, HRT really is not recommended. That is different from how it used to be in the 1980s. And that was part of the reason the trial was conducted. And so again, there just needs to be more of a conversation as to what they're looking for and what they hope to accomplish with HRT.
Okay. Our next question is a hot topic. Do the new weight loss drugs such as Wegovy have benefit for women with CVD?
Yep, it's definitely a hot topic. It's interesting. We did have a recent publication looking at the incidence of heart failure in older patients who didn't even have diabetes, who were put on the drug, and there was benefit. And so I think it supports the notion that weight loss helps lower blood pressure. Less eating probably improves your lipid profile or your cholesterol profile. And indirectly, those things over the long term would lower your risk of cardiovascular events. But again, those drugs are not till now indicated for use for those indications. Maybe that'll change. Maybe they will be prescribed for cardiovascular risk modification down the road, but that is still not the case.
Okay, thank you. Is there an alternative diagnostic test that can be used instead of an echocardiogram that utilizes a radioactive tracer?
Oh, I'm not sure. A radioactive tracer, like a nuclear test. I mean, we do a nuclear stress test. We try and avoid giving patients radiation. And so, an echocardiogram really is a perfect test because it doesn't come with radiation risk. Most of the times we can get amazing pictures, and it provides a very comprehensive view of the heart muscle, the valves, pressures inside the heart. And so, in some patients, we cannot get good pictures. And so cardiac MRI would be an option. Again, no radiation, great imaging.
And we actually received 2 questions back to back about heart attack and how symptoms present in women and how they differ from the symptoms that present in men.
Yeah.
Could you talk a little bit about that?
Sure. I didn't mention that in my talk. So I do think there are differences in how men and women perceive chest pain and angina and their heart attacks. But in general, the data does show us that the vast majority of women presenting with their episode will complain of chest pain. It may not be the dramatic Hollywood heart attack that men often come in with, is sweaty down the arm, up the jaw, central chest pain. But women oftentimes will have chest pain, and what's different is that they have associated symptoms that are unusual. So nausea is one of them, pain between the shoulder blades. My jaw was tingly. So those are some of the unusual aspects of symptom presentation for women. But I do think that the majority of women having heart attacks still present with chest pain and pressure symptoms of some sort. Okay.
So we have room for one more question. I just looked at the time. Is there, you mentioned high cholesterol as a good barometer. What about salt levels? Sodium intake?
Very important. There is a recommendation, especially if you have elevated blood pressure, to restrict salt intake to less than 2 grams a day. And I often tell this to patients, and they kind of roll their eyes like, oh, I don't put salt in anything. And it turns out that salt is in everything. And if you go to pay attention, a little less than a teaspoon of salt can be consumed very easily through the course of one day, especially if you eat out, etc. And so that is the official recommendation. If you have hard to control blood pressure, oftentimes we say to cut back to 1,500 milligrams, which is even more challenging. But the DASH diet, which is dietary approaches to stopping hypertension, is a great resource to better understand the relationship between salt and high blood pressure.
Okay, great. Thank you so much. This has been super informative. Unfortunately, we didn't get through all of the questions. We did receive several questions asking us about the new Women's Heart Clinic, so I will share a little bit more information about that. But thank you, Dr. Ahmed, and thank you everyone for your questions and for joining us this afternoon. Dr. Ahmed's office is located at the Cottage Cardiology Clinic at 2400 Bath Street, Suite 201. Immediately following this presentation, though, you will receive a link to request more information on the Cottage Women's Heart Clinic, or to have a member of Dr. Ahmed's team reach out to you to make an appointment. We will also send an email with the recording of this presentation later this week. And if you have further questions or would like more information, you can always call 805-324-9707 or visit cottagehealth.org/heart. A brief survey will appear after this webinar closes, and we'd love to hear your thoughts. So thank you again for joining, and have a happy and healthy rest of your day.